Okay, so today we're going to talk about disorders of the inner ear. So we've moved into sensory neural hearing losses. So past the outer ear and the middle ear and conductive hearing losses, now we're talking about inner ear disorders, sensory neural hearing losses. So if you look over here, the inner ear is divided into two parts. We have the vestibular system over here, which has nothing to do with hearing. This helps with balance. And then your cochlea, which is your hearing organ, and your auditory nerve. So we'll talk briefly about the vestibular system, but the vestibular system isn't the main point of this lecture. We're more interested in the cochlea for our audiology course, intro to audiology. If you go into audiology, if you want to be an audiologist, you'll learn much more about the vestibular system. So our ability to maintain balance depends on information from three systems which are controlled by the cerebellum: the visual, the proprioceptive, and the vestibular system. So your eyes provide direct information about the surroundings. The proprioceptive system is the tissue and the supporting materials of your structure that sort of, give you an awareness of yourself. And the vestibular system, which is the gravity and inertia that helps you figure out where you are at a moment. So there are these sacs, and then there are these three semicircular canals. And they share the same fluid with the cochlea. They're surrounded by perilymph and they contain endolymph. So if you remember, those are the fluids within the cochlea. They have three semicircular canals: a superior, a lateral, and a posterior. And within these semicircular canals are fluid, and there are crystals. I don't know what the real medical term is for them, but there are these crystals that sit in the fluid. And as you move your head, the crystals move and then they go back to place. And if you spin around, you make yourself dizzy, you've sort of like knocked the crystals out of space. You sit down, you still yourself. In a few minutes, you'll be back. The crystals will be back where they belong, and you'll be oriented. So like I said, again, we have these three semicircular canals. They're connected. They share the same fluid in the cochlea, but they have nothing to do with hearing. The vestibular system has nothing to do with hearing. So when the vestibular system becomes damaged or diseased, you have this sensation of whirling or spinning, right? So let's say you're healthy and you go on one of those crazy merry-go-rides. I don't know, I'm not saying that correctly, where you're spinning around, spinning around, spinning around. You feel that whirling, that spinning. What you're doing is you're actually moving that crystal in that fluid of your vestibular system. Because the connection of the brain between the vestibular system and the auditory nerve, the oculomotor nerve, is disrupted. So if you get yourself really spinny, what's going to happen is your eyes are going to dart back and forth. You're going to see this nystagmus in your eyes. So there's tests that we do in audiology to basically judge the health of the cochlear system, of the vestibular system. And one of them is called the caloric test, where in your ear canal, there's either cold air blown in or warm air. And people with normal vestibular systems, you're going to have cold air after a while. It's going to produce this dizziness. And same thing with warm air. And the response is normal, and it's subjective. I mean, this test isn't something you want to do if you can avoid it. So basically what the audiologist does with the caloric test is they make a person dizzy. And they see how quickly the dizziness comes on and how strong it is when it does come on. And they're going to measure the response of your eyes, how your eyes move back and forth. It's pretty neat to watch. Oh, I guess that's it. So we speak very little about the vestibular system here. In advanced audiology, if you do become an audiologist, you'll learn much more about it. But the vestibular system is separate from the cochlea. It is focused mainly on balance. It helps you orient yourself. There's fluid in the cochlea and the vestibular system that is shared, but the vestibular system only works on being balanced, and there are tests that audiologists do to help determine if someone's vestibular system is working correctly or incorrectly. So moving on to our cochlea, our organ of Corti, our organ of hearing. This is the inner ear, which processes sounds. So in the cochlea is the basilar membrane, and the basilar membrane is narrow at the base and wider at the apex. There are 3 to 5 parallel rows of 12,000 to 15,000 outer hair cells one row of inner hair cells. The inner hair cells are connected to the auditory nerve. Okay, so it's wider, it's narrow at the base, wider at the apex. Your outer hair cells process sound. Okay, so here are your 3 rows of outer hair cells and your 1 row of inner hair cells. This is your basilar membrane. So this runs up your cochlea. Above this is fluid and below this is fluid. This is the tectorial membrane. What happens is the stapes footplate, which rests in the oval window, will push on the cochlea and it will send the fluid in. And as it sends the fluid, it sends this wave of fluid, this piece moves up and down, right? It kind of gets sheared by the fluid movement. This thing moving up and down shears the stereocilia, or the tips of the outer hair cells. When the tips of the outer hair cells are moved, it starts like a chemical is released, and these outer hair cells move in response to the shearing of the stereocilia, and they move up and down. And as these outer hair cells move up and down, they sort of like amplify the sound one last time. And they send a message through the fluid to this stereocilia and the inner hair cell that it's time to fire the auditory nerve. All right, so you have a wave of fluid, shears the tectorial membrane and the stereocilia. The outer hair cells move up and down in response to the fluid. They amplify the sound one last time before sending a message to the inner hair cells that it's time to fire the auditory nerve. There are outer hair cells for every frequency of sound we hear. So the cochlea is tonotopically organized. It's organized by frequency. We process the very high frequencies at the base of the cochlea and the lower frequencies further out. Here's another picture of our 3 rows of outer hair cells and our 1 row of inner hair cells. Here they are in real life. These outer hair cells are so important for hearing. If they're damaged or destroyed, you are going to have a sensory neural hearing loss. Okay, so this is everything that I just said. You can read over it more carefully. Like I said, the cochlea is tonotopically organized. So very high frequency sounds are processed at the beginning of the cochlea. And then as you go up, we have mid-frequency sounds, all the way to the top of the cochlea, low-frequency sounds. So there's a traveling wave. The stapes sits right here. It pushes the fluid. As the fluid moves, it creates a wave. The fluid goes to its best frequency on the cochlea. The outer hair cells excite, and the wave disappears. So for high frequencies, the sound will go right to where it belongs. The wave will excite, and then it'll disappear. If it's a low frequency, the wave has to travel farther along. It'll travel. It'll hit its mark. The outer hair cells are going to move up and down, and it'll disappear. So there are outer hair cells for every frequency of sound that we hear. We hear from 20,000 hertz all the way to 20 hertz. And you know why dogs and deer and other mammals hear sounds that we don't hear? Well, they have a longer basilar membrane. So for example, let's say a dog can hear a whistle at 40,000 hertz because the dog's cochlea wraps around more. So they have the outer hair cells to process those very, very high frequencies. We don't have the outer hair cells to process them, so we don't hear the dog whistle or the deer whistle. Okay, so any disorders produced by abnormality or disease in the cochlea are sensory neural hearing losses, and sensory neural hearing losses are the largest group of hearing losses. So with this sensory neural hearing loss, you could have areas of normal hearing and areas of profound hearing loss. For example, we tend to lose our high frequency hearing first, right? That's presbycusis, that's that age-related hearing loss. A person may have damage all through here, but then this part of the cochlea might be A-OK. So you can have areas where you don't hear certain frequencies and areas where you do hear certain frequencies. It all depends on the health of the outer hair cells. And when the cochlea is damaged, it's not just hearing sensitivity that people complain about, it's the difficulty understanding speech, because they can hear some frequencies, but they can't hear all the frequencies. So they hear enough to know that speech is happening in the background, but they don't have enough information to really fully understand the message. So the number one complaint for people with this type of hearing loss, with presbycusis or sensory neural hearing loss, is I can hear you, but I can't understand you. Alterations in the structure or the function of the cochlea produce more hearing losses than any other abnormalities in the sensory neural system. So you're much more likely to have a cochlear hearing loss or a problem in the outer hair cells than in the auditory nerve or in the inner hair cells. There are prenatal causes of hearing loss. Prenatal is before birth, and they can have an effect on the normal development of the cochlea. So most hearing losses are genetic, and they're caused by a genetic recessive gene, so the parents don't even know they have it. To review your biology courses, all hereditary information is incorporated on our DNA, which contains genes, and they're the blueprint for our hereditary code. The genes manifest themselves physically, and we have the genetic makeup. So your phenotype is the physical manifestation of a trait, and the genotype is the genetic makeup. So going back to, you probably learned in your biology classes, blue eyes, right? So the genotype for blue eyes would be little b, little b. You need a little b from mom and a little b from dad, and the phenotype would be blue eyes. If you were to have brown eyes, you could either have a big B from mom and a little b from dad, or you could have two big B's. So the phenotype is the physical manifestation, the genotype is the genetic makeup. All of our genes are strung in a bead-like fashion along chromosomes. We have 23 pairs of them. One chromosome from each pair is inherited by a parent, and it's randomly selected. Different forms of a gene are called allele. So for example, a baby may have blue eyes, and allele for blue eyes must be inherited from both parents because it's a recessive trait, so it's homozygous. To have brown eyes, which is a dominant trait, it's heterozygous. You just need to get one gene with the big B from either mom or dad. When a gene from one parent is required for a trait to be shown, it is called autosomal dominant. And when you need the gene from both parents for the trait to be shown, it is recessive. Autosomal recessive inheritance accounts for about 80% of profound genetic hearing impairments. So the child has to inherit an allele from both parents. Some of these, about half, are associated with the syndrome. The genetic, this isn't very it's not uncommon to have hearing loss. In fact, it's the number one birth defect, and oftentimes these children are born to parents that have normal hearing, and they don't know of any other family members with hearing loss because it tends to be a recessive gene. And I'm not necessarily talking about bilateral, profound hearing loss. It could be a moderate hearing loss, it could be a unilateral hearing loss, it could be a mild hearing loss. They're recessive and they're more common than we think. So children with autosomal recessive hearing losses, they usually have two parents with normal hearing that carry the recessive gene. So I think about a third of the population carries this recessive gene for hearing loss. And with each pregnancy, there's a 25% chance that the gene is going to be passed on. Okay? So each normal hearing child has a 2/3 chance of being a carrier. So you have to go back to that Punnett square that you learned in biology. Let me see if I can draw it for you. I guess not. All right. Sorry about that. Anyway, so you have to imagine one parent with the dominant gene and a recessive gene, and another parent with a dominant and a recessive. You have a 25% chance of having a child that that's not a carrier and that doesn't have hearing loss. And you have a 25% chance of a child having hearing loss. Then you have 2/3 a chance, the other two, of a child not having hearing loss, but of being a carrier for the hearing loss. Now, some forms of hereditary hearing loss are also associated with other abnormalities. If the hearing loss is associated with other abnormalities, it falls under the category of syndrome. So whenever a group of symptoms is considered together for a diagnosis of a particular disorder, then you have a syndrome. So with Down syndrome, a child might have an enlarged heart, their ears might have microtia, there might be developmental delays. There are a few things happening, and it falls under the label Down syndrome, or syndrome would be the umbrella term for a few things happening on. So there are some forms of hereditary hearing loss that are associated with other abnormalities: cleft palate, optic disorders, changes in the eyes, the hair, the skin, pigmentation, thyroid, disorders of the heart, mental retardation, and sensory and motor deficits. There are chromosomal abnormalities that might be associated with hearing loss. So at times, portions of chromosomes may be missing or extra material would be found. So with Down syndrome, there's a third chromosome for number 21. Instead of having a 21 from mom and a 21 from dad, there's a 21 from mom, a 21 from dad, and another piece of a chromosome. Other prenatal causes of hearing loss include the Rh factor, in which the fetus's blood type is different from that of the mother, and the fetus's blood contains the protein Rh that the mother doesn't have. So the mother produces antibodies to protect against the harmful protein, and with each pregnancy, she develops more and more antibodies that attack the developing fetus. This isn't as common anymore because doctors can now diagnose it early on in the pregnancy, and they can monitor the mother and give her treatments. There are other prenatal causes of hearing loss: cerebral palsy, congenital damage to the brain or the motor sensory system, rubella. There's a reason we vaccinate, okay? So kids are vaccinated to prevent diseases such as rubella. A symptom of rubella is hearing loss. Viral infections cause hearing loss. Most of the damage is done in the first 3 months when the inner ear and the sensory neural system are still differentiating. So if the mother gets sick with rubella, mother gets sick with a viral infection, anoxia, oxygen deprivation can cause hearing loss. CMV, which is a branch of the herpes virus, could infect the developing fetus and results in a variety of physical symptoms. Some children have sensory neural hearing loss. It could be contracted through the placenta, from the cervix during birth, or from the mother's milk, but that's less likely. This stuff, doctors have stuff to monitor this and stay on top, so you don't have to be, too scared that this would happen to you, but you need prenatal care. There are hearing losses that could occur during the process of birth itself and result in multiple handicaps. For example, anoxia, or deprivation of oxygen, could cause damage to the cochlea, the central nervous system, the umbilical cord is wrapped around the neck, or if there's problems with the umbilical cord itself, the placenta being dislocated, toxic substances in the blood. Prematurity is also a risk factor for hearing loss. Infants weighing less than 1,500 grams, incubators in the NICU with high noise levels. Other factors that could occur after birth, like otitis media, a very serious ear infection that enters the inner ear. Remember I said untreated ear infections are a number one cause of death in children in developing countries. Bacterial meningitis could cause total deafness. This is an infection of the meninges, and with bacterial meningitis, what happens is the cochlea is ossified if it's not caught or treated early. But now we have vaccines for meningitis, which is really cool. We didn't have that 20 years ago. Viral infections, like I said, the measles, the mumps, rubella, there's a reason that we vaccinate. Syphilis, brain or cochlear damage, any sort of infections in the brain. There are toxic causes to hearing loss. Some antibiotics could cause hearing loss. I know a woman, they had a baby. Around 7 months, the baby had cancer. So they had to put the baby on some ototoxic medications to treat the cancer. And the baby's since lost its hearing. But the baby will have cochlear implants and hearing aids, and I'm sure it'll be okay. But sometimes if the choice is an ototoxic medication and losing the hearing, or something much worse, you're going to go with the ototoxic medication. Aspirin in high doses, nicotine, alcohol, large amounts of anything aren't good for anybody. There could be noise-induced hearing losses. Noise-induced hearing losses, for example, a temporary threshold shift. If any of you have gone to a loud concert, and when you leave the concert, your ears just don't feel right, or your ears are ringing, or you feel like you don't hear as well, chances are you don't. You might have a temporary threshold shift, which is a hearing loss that results from intense noise, or it could be the result of a brief exposure of high sound levels. Maybe after a day or two you go to bed, the next morning your hearing is better. That would be a temporary threshold shift. If you do that every week, you're going to end up with a permanent threshold shift. You're going to end up with hearing loss from noise. Noise-induced hearing loss is a loss of those outer hair cells and the supporting structures at the base of the cochlea. You could have nerve degeneration, biological changes in the sensory cells, physical dislodging of the outer hair cells, damage to the cochlear blood supply. Whenever your ears ring, whenever you have tinnitus and you hear your ears ringing, I want you to think of your outer hair cells screaming, "Help us, help us." So that ringing is like your outer hair cells slowly dying. You don't want to expose your ears to loud sounds for extended periods of time. You don't want to hear that ringing. It's not a good sign. Acoustic trauma from impulse noise or industrial noise can cause noise-induced hearing loss. There are guidelines from OSHA. I don't know if anybody have heard of OSHA. It's a government agency that recommends guidelines for workers, and it'll go into factories and offices, and it'll say, workers can't be in, for example, 85 decibels for an 8-hour workday, or workers could be in 90 decibels for only a 4-hour workday. So OSHA measures how long it's safe for a worker to be exposed to an intense sound. The louder the sound, the less time they're allowed to spend in that sound. They use sound level meters to determine whether or not how loud a sound is. I have a friend that did a study in the New York City subways where they went around and they used a sound level meter and they measured the level of noise in the subway tunnels, in your subway, in this platform area. And I think some outrageous number, basically they're all too loud for our hearing. They're all going to cause damage. And that subway platform down in Union Square where the 4, 5, and 6, where it curves around, that was like off the chart on the sound level meter. It was so loud. It's so bad for us. If you do nothing else but ride the subway or commute to work for 20 years back and forth, you're pretty much guaranteed some degree of a hearing loss. There could be cochlear hearing losses following surgery. So if a person had vertigo and the doctor wanted to do some sort of surgery, they might do damage to the hearing. There is sudden idiopathic sensorineural hearing loss. This is really scary. This is just a hearing loss that develops over the course of a day, or it could just a few days, or it could just happen instantaneously. It might be brought on by an autoimmune disease, a viral or other infection, a rupture of the basilar membrane, a tumor, or a neurological disorder. I met a man, it was so sad. He was saying that, he had a big position in an office, and one day something happened where he was on his phone and he couldn't hear, and he was shouting at his secretary through his phone, "Speak up, I can't hear you, I can't hear you." And it turned out that he just had this sudden idiopathic sensorineural hearing loss. Permanent when I saw him. It had been a year or two since then. It can occur at any age. A way to treat it is if you get to the hospital really fast and they inject steroids into your inner ear. Meniere's disease is something else that you don't want. It is a sudden, unilateral, one-sided fluctuating hearing loss. It's like it just comes on fast, and it could be extremely handicapping without warning, and it could be sudden attack of vertigo, tinnitus, vomiting, unilateral hearing loss. The symptoms could come and go. It could be done in a day. It can come back in a week. It might only come back once in your life, or it might come every month. I think that's what makes it so frustrating, is the unpredictability of the Meniere's disease. And I don't believe we really have a way to treat it. Head trauma could also do damage to your inner ear. So when your cochlea is torn, stretched, or deteriorated, let's say you're in a car accident or you're hit in the head, if you have fracture, skull insult, the hearing loss could be severe to profound. Finally, we have presbycusis, which I've been talking about a lot all semester. Presbycusis is hearing loss due to aging. There are no contributing etiological factors to hearing loss except for the advancement of age. So basically, you get old. Some people have a genetic predisposition to this. You've experienced a lot of noise exposure. Men, it tends to come on in their early 60s, and women in their late 60s. You would have difficulty with speech recognition. Even making sounds louder, they're still difficult to understand. Remember that number one complaint is I can hear you, but I can't understand you. 45% of adults over the age of 65 have some form of this hearing loss. The hearing loss could be handicapping in social, emotional, vocational, and psychological areas. In one of the last chapters in the semester, we'll talk more about it, and we'll definitely talk a lot about it in oral rehab.